Thank you for having me. It's great to see such a fantastic attendance, actually. Well done to the organising committee for that. Um, as Tamara said, I'm Claire Hogg. I work in London with Amelia, and we run the diagnostic service there. I've been asked today to talk about the spectrum of disease severity in PCD, and in the slides that have been circulated already, some of those you will see in the pack if you are looking at the slides with this conference. I haven't included talking to all of them in this talk just because of the time constraints, so apologies for that if you see that there are extra slides that I'm not going to talk about today. I think what I'd really like to start off is just, let's see if I can get this to move on. Has that moved on for you? Yeah, is to talk about the challenges we have around PCD in terms of not just diagnosing it, but actually assessing clinical manifestations. I know you've had talks from Amelia and Myrona already, but it's really genetically and clinically complex picture. We know that this is not a trivial disease, but we also know that there is quite a broad spectrum of severity, and that spectrum of severity is not just between specific mutations, but within some of the mutations themselves. And that's because we have variations in splicing, missense, truncating defects or mutations, if you like, that might impact what the protein expression is. So that's the downstream impact of the genetic mutation might be quite variable, and that influences some of the manifestations that we see. And so there's an awful lot that we still have to learn about that. But we, of course, we do know, because we're good at collecting large data now across this relatively rare condition, some of the clinical manifestations and the genotypic phenotypic correlations that we can start to work with. I think you've talked about prevalence. It is increasing. The figure we use now is 1 in 7,500. There was a question in the chat about that, actually. It is difficult to quantify because some communities, PCD is actually as common as cystic fibrosis is. So cystic fibrosis is our most common inherited condition in terms of Northern Europe. So I'm speaking from London in Northern Europe. But in other parts of the world, PCD is probably more common than cystic fibrosis is, for instance. And I think that's relevant because I'm going to talk about that as part of the challenges we have. We know it's multi-system, and although it's dominated by the respiratory morbidity, the severity can actually be related to other multi-system pathologies. So I think you've probably talked about congenital heart disease. I heard Myrona mention hydrocephalus, whether you've got a spleen, and I've seen that in the chat as well. You can have polysplenia or asplenia, but you might have poor splenic function. And all of these things can, of course, contribute to your wider morbidity associated with the condition. These 4 points I just wanted to make here are that the diagnosis and management of PCD is actually complicated by some of the challenges we have in terms of raising awareness. We have quite a few missed opportunities to pick up PCD, I think, and get people started on treatment before they have developed long-term or irreversible lung damage. And never more so than in the neonatal population. 3/4 of patients will pass through some sort of neonatal or special care baby unit because they need respiratory support. Might be oxygen, they might be fully ventilated. It could be days, and it could be weeks or even months in rare cases. But it's surprising how few of those patients are referred on for diagnostics, even in the presence of situs inversus or other of what we would consider obvious clues that people should be considering PCD. So they'll graduate, often without a diagnosis, out of the neonatal intensive care unit, and then represent in those early childhood years, so preschool, primary school years. And again, they often get overlooked because the overlap of their symptoms, the cough, the runny nose, the glue ear, overlaps with what's very common clinical symptoms for all children that age. We know that all children get glue ear, or to a degree, wet cough, frequent infections. And so again, they might pass through there, and that might be because someone hasn't asked about their neonatal history, for instance. And then we have this tendency to exclude cystic fibrosis and move on. So the vast majority of patients, I would say internationally, people will be thinking that they need to exclude cystic fibrosis. In the UK, we're fortunate enough to have a newborn screening program for that now, but cases do get missed and we still look to exclude it. Patients who don't have cystic fibrosis but develop bronchiectasis sit in clinics called non-cystic fibrosis bronchiectasis. But that already, just by implication, means that we're not thinking about PCD as the other main inherited condition that causes bronchiectasis. So just by calling those clinics non-CF bronchiectasis, there is no responsibility for the clinical teams to then think, actually, it's not cystic fibrosis, but it could be PCD. We should be thinking that this is a non-inherited bronchiectasis clinic. So what do I need to exclude for a patient to get in there rather than to go into a different clinic where all their comorbidity care will be better catered for? And then, of course, you've talked about the complex variety of diagnostic tests. We are very fortunate with our commissioning here, but we still have geographical challenges for patients who have to travel many hours to get to the 3 centres that we have. But globally, resources and expertise are much more varied because there isn't a focus on commissioning these services. And so that obviously leads to inequities. Why is diagnostic rigor so important? Well, if we want to identify geno-pheno correlations or disease associations, comorbidities, spectrum of disease, we need to have really rigorous diagnostics, and that includes genetic testing. It's important at a diagnostic and a clinical level. And of course, we're on the advent now of some disease-modifying or gene-based therapy trials starting. So it's really important for us to be able to deliver patients who have got their phenotype and genotype secure. We've talked about this clinical spectrum of severity, and we'll go on and talk a little bit about what we do know and what we don't know. There's quite a lot we don't know. But there are clues all the way through, from the antenatal all the way through to being born or when they present in pediatric or adult life for diagnostics that we can pick up. So, for instance, on the detailed scan, they might pick up the situs abnormality, a congenital heart defect that can be more common. There are specific types of congenital heart defect associated with PCD. Ventricular megaly, that's the expansion or dilatation of the spaces in the brain that leads to hydrocephalus in some cases. So all of those might give you an indication that actually there are going to be certain comorbidities that might impact your clinical manifestations. We've talked about the neonatal respiratory distress, the laterality defects, and all patients or most patients would suffer from the sort of, on the bottom line here, this clinical trio, if you like, of otosinus disease, chronic obstructive lung disease, which is that bronchiectasis, productive cough, and reduced fertility. But some patients will have more in the way of upper airway ENT problems than others, and others will be more troubled by their lungs, or some obviously with both. So all of these are issues. This is a slide Hannah Mitchison gave me. We did a joint talk to the American advocacy group, the PCD Foundation, earlier in the year. And I've just put it up because it's a really nice way of demonstrating how genes can offer broad clinical predictors, not just for what we see in terms of our comorbidities, but also what we see diagnostically that can be so important for us. And in black, you can see the mutational class that she's looking at, in red, the diagnostic phenotype, and in blue, the clinical phenotype. And I'm not going to go through all of these because I don't have time, but this is a ciliogenesis defect. So at the more severe end of the spectrum, where you have early onset lung disease, it's more associated with hydrocephalus and infertility. And you can see in red what we're likely to see in the diagnostic lab. And if you go around here, this is the syndromic cases. So they might have a primary ciliopathy that gives them neurological, retinal, skeletal, sensory neural hearing loss, very variable motility. And I'll show you a slide of what these look like. They present as though with a respiratory ciliopathy that presents just like PCD. And they have these syndromic other issues. But if you go around, and I won't go through these, you can see all the various places that our genes impact ciliary function, if you like. And you can see we get very different beat patterns in red and some of the known associations. So some of these you'll see are associated with situs defects or heterotaxy syndromes, and therefore in that smaller group, higher risk of having congenital heart disease or absence of the spleen, and some are just not associated with situs abnormalities at all. So these are known clinical associations that can impact your manifestations and your disease severity. I'm not going to go through the slide. I've included it in the pack because it says more or less what I said in the last slide, but it has all the publications. So for people that want to do a bit of wider reading, all the publications are listed there. And again, that's courtesy of Hannah Mitchison. So I think just before I sort of go through the last couple of slides, I think it's really important to understand where we are with our knowledge about disease severity. So not all genes leading to the same ultrastructural defect, so let's say DNAH5, leads to an outer dining arm defect, so loss of the protein, and you see absence of the outer dining arms, and you tend to see static cilia. Not all of them have the same clinical manifestations, and I'll show you a study that we did looking at this. Different variants within the same gene can result in loss of function in a protein, so there is absence and complete loss of function, or reduced function in that same protein, with significant differences in their clinical presentations as a result. And actually, just interestingly enough, last week we were doing one of our diagnostic meetings, and we had a genetic diagnosis for a patient with DNAH11 homozygous pathogenic mutations, but we didn't see loss of staining for DNAH11 when we applied the immunofluorescence antibody test. They were missense mutations, and that shows that there is partial expression of that protein to the point that we were seeing some on the staining, whereas when you have total loss of that protein, you would have absence of staining for DNAH11 using the IF technique. So we don't know yet, this is a young child, whether this child will have less severe disease because of those missense mutations and partial expression of the protein. So it just is a sort of description, if you like, about how complex this is. These are a couple of studies I just wanted to, sorry, I know my time is up, but very quickly, and you can read the slides. This is the Chapel Hill group, looked at one of the more severe, known to be more severe mutations, CCDC39 and 40, which give inner dining arm and microtubular defects, and they were comparing FEV1 to weight and height. And you can see here in red that compared to outer and inner dining arm defects, FEV1 and their BMI metrics are worse. And this is data we've been able to do comparisons, not just with healthy controls, which are in the bottom line here, but with other mutations. And here you can see compared to DNAH11, which is deemed milder, outer dining arm and outer and inner. And again, it's at the top on this column, you can see how much worse that is. And then this is an imaging study done by Brianna Kinghorn's group, where they were looking at CT imaging, and they showed in that same group with the inner dining arm and microtubular defects how they had increased mucus plugging and increased disease, although not much difference in terms of bronchiectasis, wall thickening, and atelectasis. So quite interesting. And they're trying now to automate the analysis of CT chests. And imaging wise at the Brompton, we're doing a lot of work around MR imaging in this functional and structural work, which of course is radiation free, but we're hoping this will become a good way to monitor disease going forward. These very quickly, this is the topological data analysis or cluster analysis, if you like, of specific phenotypic things. And they looked at FEV1 and neonatal respiratory distress, and they compared these three genes. So deemed more severe, mild, and much more heterogeneous or diverse. And they compared them to FEV1 here and neonatal respiratory distress. And you can see here the severe lung function or the presence of neonatal respiratory distress is in the dark blue and the red. And when you look at this, it's very much focused on where the dark blue and red is for CCDC39, and for DNAH11, where it's pale blue or white. that's where you see the focus, and here for DNH5, much more distributed across the patch. And that was the UK data, and we did a replication cohort or validation cohort, if you like, and saw exactly the same findings. So quite a nice way to bring big data together to look at these clinical correlations. I just wanted to show this because we have this emerging group of patients in our clinics, certainly here in the UK, with overlapping features between motile and primary ciliopathy, so what we call the syndromic ciliopathies. I've listed some of them here. They have a PCD-like phenotype, and you can see these rather odd changes that doesn't look like classic PCD, but you have these long whip-like structures with these paddle sort of bulbous tips, if you like. Let me just point them out here. And on electron microscopy, this is a normal cross-section. You can see these huge inclusion bodies. But what's interesting in terms of clinical spectrum of severity is often there seems to be a modifier effect on the primary ciliopathy. And we have these patients with Joubert's mutations without the full spectrum of syndromic features. And we're not really sure what causes that, but it's again another indicator of how complex this is. Is there a moderator effect from having the respiratory ciliopathy on their syndromic features? And then finally, just to reiterate how important these big groups are, BEAT-PCD, fantastic work, ERN lung, ClinGen, the rare diseases group in North America. I mean, just so important to us to have these groups and these consortia to advance this work and improve our understanding. Thank you. Sorry, I've run over by a couple of minutes.